Good evening.
You are now muted.
Reston Hospital Center webinar series. Tonight's topic is colorectal cancer, treatment of a preventable disease. Our speaker is Dr. Lawrence Stern from Fairfax Colon and Rectal Surgery. Dr. Stern will give an overview of colorectal cancer, share preventative measures, and answer the three questions he gets most from patients. Why me? Will I need a colostomy bag? And am I going to die from this? Tonight's program should take less than 1 hour. During the presentation, if you have any questions, you can send them via the online chat window. Dr. Stern will answer your questions live at the conclusion of this presentation. And now, let me turn the program over to Dr. Stern.
Well, thank you, Doug, and thank you to Reston Hospital for allowing me to give this presentation, especially given that March is Colorectal Cancer Awareness Month. As Doug said, my name is Lawrence Stern. I'm a colorectal surgeon practicing in the Reston area, and I'm going to answer these three questions, or try my best to answer them. And these are the three questions patients will either ask me or, in fact, want to ask but are afraid to ask. And I'm going to try to answer some of the questions now. Why me? Will I need a bag or a colostomy? And obviously, am I going to die? So let's break that down a little bit. Where does colorectal cancer come from? What causes it? How is colorectal cancer treated? What does the surgery entail? How often is a stoma necessary, and will it be permanent? And what determines prognosis? How can we improve the prognosis? And most importantly, probably in this entire talk, how can we prevent having colorectal cancer in the first place? So let's just start with a little anatomy to refresh everybody's memory. The large intestine, or the colon, is about 5 feet long. It does nothing more than absorb water. It really doesn't have a true role in nutrition, and that's why patients can live quite well without a colon at all. The rectum is actually the last 8 or 10 inches of the colon. Its job is simply to store waste. It's very soft and compliant, and this is what allows people to defer their defecation to a time that's convenient to them. Colorectal cancer is quite frequent in the United States, approximately 150,000 new cases per year. It represents the third most common cancer for both women. It represents the second leading cause of cancer death, and its incidence among races is essentially equal. The average age of diagnosis is approximately 62 years. When you look at how colon cancers are distributed along the anatomy, it's not equal. The vast majority of colon cancers occur on the left side of the colon, approximately 65%, with about a quarter on the right side and a very small percent on the middle portion, or the transverse colon. And that has bearing on the type of surgical procedures we need to perform. So let's talk about what causes colorectal cancers. This can be broken down into polyps, genetic factors, environmental factors, and we'll just simply term the rest as other risk factors. Classically, colon cancers were thought to develop from what we call the adenoma to carcinoma sequence. This was a progression from a completely normal colon, seen here, to a small polyp, a much larger or pre-invasive polyp here, and then finally a colon cancer. And typically this was thought to occur over approximately 7 to 10 years. So why does this occur? Well, colon cells are constantly being sloughed off and replaced throughout a person's life. And the more cell turnover we have, the increased incidence of genetic mutations when cells are dividing. This can lead to polyp formation. Everybody has repair genes that help prevent and fix mutations in these cells that are rapidly dividing, but when a repair gene becomes defective, a polyp can form. Some patients are at increased risk because they have inherited mutations in their repair genes, and these patients are subject to cancers developing at an earlier age. Other genetic mutations can occur because of environmental effects. So, of the genetic factors that we know about, less than 5% of colorectal cancers are due to an identified inherited mutation, ones that we can test patients for. Approximately 25% are termed familial, but these are just cancers that are grouped among patients who have a family history, but we don't know what gene is actually causing it. And finally, almost 3/4, or the vast majority of cancers, are sporadic. There's no family history, there's no known genetic mutation involved. So when we break this down into the hereditary colon cancers, we look at two main categories: FAP, which represents a very small fraction, about 1% of patients with colon cancer, and these are patients that develop hundreds and many times thousands of polyps at a very early age. Approximately 100% of patients will actually go on to develop colon cancer by the age of 40, and that's why these patients, if they're known, are offered colectomy at a very, very early age. HNPCC, which is strangely named hereditary non-polyposis cancer coli, represents less than 5% of cancers, and the term non-polyposis is somewhat misleading. These patients actually do develop polyps, they just don't develop the number of polyps seen in the previously discussed FAP. Patients in this category develop cancer at a much earlier age, typically under age 50. Unlike the previous discussion about where cancers originated in the colon, these are more frequently on the right side. Patients with HNPCC actually have a much higher rate of forming other colon cancers within 10 years of the first cancer, and they also have increased risk of other cancers. In women, we specifically look for endometrial cancers, and in certain cases, women will elect to have a hysterectomy to prevent this from occurring at a later point. There are currently approximately 6 different genes that have been identified with HNPCC, and with the current genetic testing, these can actually be screened for. And finally, there's what we just determined undefined familial colorectal cancer. This is the remaining 20%, a very strong history, but at this point, we haven't figured out what gene is leading to these cancers. When we look at the environmental factors, these are relatively weak compared to the genetic issues. Diets low in fiber and high in fat seem to have an increased risk, but this is not at the same magnitude as other factors. Activity level, a sedentary lifestyle seems to increase the risk to some degree. Excessive alcohol intake can increase the risk by 1.5 to 2 times. And more recently, a lot of research focus has been on the colonic biome, the role of bacteria in the colon. There are many people who now take probiotics with the theory that the healthy bacteria can replace the, quote, unhealthy bacteria in the colon, and what role that actually plays in forming cancer is not known, but is actively being investigated. Other risk factors would include inflammatory bowel disease such as ulcerative colitis and Crohn's disease, and prior radiation exposure. So let's talk about how we treat colon cancer, and I'm going to break this down into colon cancer and rectal cancer because these are two different treatment strategies, but this is the same actual type of cancer, and we'll talk about that a little bit more. Colon cancer is a really much more straightforward evaluation. Typically, surgery is the primary mode of treatment. We rarely use radiation in the treatment of standard colon cancers. On the other hand, rectal cancer is a much more complicated surgical disease. It requires much more extensive preoperative workup. The surgery itself is more difficult and requires additional skill sets. And these cancers are frequently treated with a combination of both chemo and radiation therapy before surgery is offered to help improve the results. So when we talk about a colon cancer, we use colonoscopy not only to diagnose the cancer, but also to make sure patients don't have other polyps or another cancer at the same time that would need to be addressed during the treatment of the primary tumor. Typically, patients will receive a CT scan of the chest, the abdomen, and pelvis, looking for any evidence of spread into the lungs or the liver or anywhere else in the abdomen. This is what we term distant metastasis. PET scans are a newer method of evaluating for distant spread. They're currently not the recommended approach, but they can be used in certain circumstances, and they can help clarify situations where the CTs are unclear. Patients do get a baseline CEA level, so this is simply a blood test and measures a tumor marker. Unfortunately, this is neither sensitive nor particularly specific for colon cancers, but we do like to get the level ahead of the surgery. That way, if it's elevated, we like to see it fall back to a normal level after surgery, and then this can be used by oncologists to follow patients long-term to look for any evidence of a rise at a later point. When we operate for colon cancers, we have several principles we follow. We want to make sure we have a large margin around the cancer. We need to take a portion of the colon both in front of it and after it to make sure that there's no microscopic spread that we have left behind. Most importantly, we need to remove all the lymph nodes surrounding the colon, and this we'll get to with some pictures to help explain that. We also need to make sure we maintain a good blood supply to the connection. It doesn't help if we take out a segment of the colon, put it back together, only to find out that that portion of the colon won't survive, and then we have significant complications. We also have to make sure when we put the colon back together that there's no tension, that we can't be pulling on that connection point, or the term we use is the anastomosis. Our goal obviously is to maintain bowel function to the best of our ability, and we can tailor the surgeries in most circumstances to achieve that. And finally, nowadays, most of the surgical procedures we performed can be performed in a minimally invasive fashion, and we'll talk about that a little bit more later. So from an anatomic standpoint, patients with tumors on the right side, either here in the cecum or the ascending colon, and then extending over to the transverse colon, will wind up with a right colectomy. And in this case, you can see that this dotted line includes the portion of the colon with the tumor. Even if the tumor was here, we have to take it past it for the margins, both in front and after. But we're also dividing the blood vessels here to make sure we incorporate all the lymphatic tissue that's involved. And this is really important for prognosis and staging. So sometimes patients will come to the office, they'll have a small cancer in the cecum, and they expect us to just take a little bit of this colon out and put it back together, and they're really quite shocked when we're drawing this picture showing them that we're going to take out this entire section, and they're kind of looking at you a little bit panicked. But you have to explain that this is all based on the blood supply and the lymphatic tissue, and making sure we're able to completely finish their cancer. After we remove this section, we take the small intestine and we reconnect it back to the colon, and that's usually done right at the same time as the first operation. These patients rarely require ostomies or bags. We're able to put the colon and the small bowel back together. Left colons, you can see here, tumors on this side similarly require division of these blood vessels, so we get the blood supply, tissue, proper margins, and once this portion of the colon is taken out, we drop that colon down and connect it back to the top of the rectum, and you can see this portion of the colon is now missing. So we have various approaches we can use depending on tumor location. We've talked about a right colectomy and a left colectomy. A subtotal colectomy is where we basically remove all of the intra-abdominal portion of the colon, and then we connect the small intestine to the top of the rectum. While this may seem extreme, these are used for cases where patients have known hereditary syndromes, where they're at very high forming future cancers, patients who have multiple cancers spread throughout the colon where we can't really retain any of the colon, or patients that have already had a portion of their colon taken out and then years later come back with another cancer, or what we call metachronous cancer, and they need the remaining portion of their colon removed. As I stated, most of these patients do not require an ostomy. These are used in selective circumstances such as emergency procedures where the colon is either blocked or has perforated, or patients that are so sick that they really couldn't tolerate the colon and the being put back together safely, and in those cases we'll bring up a colostomy to help let the patient get back to health, and then at a later point we typically could put that back together. Nowadays most of these are done in a minimally invasive fashion, and the vast majority, over 90%, can have normal bowel function maintained. This assumes that the rectum is okay and the patients have a normal anal sphincter to begin with. As I was talking about, minimally invasive surgery nowadays includes laparoscopic surgeries and robotic surgeries, which I'll talk about a little bit later. But in the laparoscopic approach, typically we use 3 or 4 small incisions instead of one large incision. And these surgeries offer patients the advantages of less pain, a quicker return of bowel function, quicker return to work at home. And the most important aspect is that the cancer results are identical between a laparoscopic and an open procedure. I'm going to turn to rectal cancers, and as this slide says, a whole different animal, because it truly is. And the confusion between a colon cancer and a rectal cancer is that patients think they're actually a different type of cancer, and they're not. It's the same cancer in a different anatomic location. And the reason rectal cancers are so complicated is you have to think of where they're located. These are tumors sitting in the deep pelvis, trapped between very important structures. The bladder, the rectum sits here, the tailbone and the sacrum sit here, but lodged between here, in men we have the prostate, in women we have the vagina, we have the blood vessels going to the legs, we have the connections from the kidneys to the bladder. These are all lodged in a very tight pelvis trapped by the bony structure. And as a result, we can't simply get around them as easily as we can in the colon. And this in the same location is higher than it is in colon cancer. And as we talked about, you need to have a margin. So if this tumor sitting here was located here, low down in the rectum, getting below it requires you to take the anal sphincters. And if that happens, then patients cannot be put back together because there's nothing left below it. So these cancers are staged differently or worked up differently. We obviously try to simply feel where the tumor is to get a sense of its location, where it sits, left, right, front, back. We do what's called a rigid proctoscopy. That's where we simply look with a scope that doesn't bend, unlike a colonoscopy where the camera bends. This lets us determine exactly where this tumor sits, and once again, where it's located front, back, left, or right. Additionally, these patients almost invariably will undergo additional staging with either a transrectal ultrasound or a pelvic MRI. And these studies are critical because they help us determine whether or not this cancer has spread through the wall of the rectum or whether it has spread into the lymph nodes surrounding it. We continue to use scans of the chest, abdomen, and pelvis to look for evidence of spread. And once again, PET scans can be used, but right now the recommendation continues to be for standard CT scanning. Part of the treatment change that we see in rectal cancers is that if the tumor has penetrated through the wall, like in the picture, or the lymph nodes are positive, then these patients are frequently offered preoperative chemo and radiation therapy. And that's why ultrasound and MRI is so important. This is what helps us determine whether or not a patient is going to get this therapy. Preoperative chemo radiation therapy is used to both shrink the tumor and is designed to clear the nodal tissue that may be beyond the reach of our surgical approach. It has been shown to decrease the rate of local recurrence following surgery. So these are some diagrams of the surgical approaches. A low anterior resection means removing the rectum all the way down to the anal canal. It's typically done 6 to 8 and sometimes now 10 weeks after the radiation therapy has been completed. This sometimes mystifies patients. They want it out as soon as possible, but we have to slow the process down and explain to patients that even after they've undergone the chemo and the radiation therapy, the tumor will continue to shrink, and we want to take full advantage of that. When radiation is given and we take out this portion of the colon and the rectum and connect it back together, we will typically use a temporary ileostomy. And basically that's this. We take the small intestine here, we bring it up to the abdominal wall, and we basically slit it and let it come up here and act as a circuit breaker. What happens, patients eat, the food comes out, the waste products are collected here, nothing travels into the colon here, and this connection point is protected. We allow this to heal while the patient continues on their chemotherapy that is typically required after surgery. And once chemotherapy is completed, we will check this connection, make sure everything is okay, and then we take this down and close the circuit breaker and things start moving back through. Alternatively, like we talked about, if the cancer sits too low, it may be impossible to get below it, and these patients get what's called an abdominoperineal resection, or frequently called an APR. This requires a permanent colostomy because the anal canal is taken out and there's nothing left below. This is a non-reversible situation. So these two procedures, the low anterior resection and the abdominoperineal resection, are technically very difficult procedures. They have much higher risks of complications both during the surgery and after. They have significant changes on the bowel function, but they can be performed both in the standard open manner, a laparoscopic manner, or a robotic manner. So quickly, I'm going to talk about a robotic colectomy. This is basically a fancy laparoscopic tool. You can see the robot here, and you'll see this person here, and many people think, oh, there's the surgeon working the robot, but quite frankly, that's not true. I'll show you where the surgeon is in just a second. But what the robot offers is greater magnification, 10-fold increase in magnification, and most importantly, it's a three-dimensional image. It's two cameras mounted side by side, and a computer system that translates that into a 3D image. In addition, the instruments on a robot are what we call wristed. They bend. They allow the tips of the robotic instruments to travel, to bend, and get around little corners and tight spots that we cannot do with a laparoscopic approach. So if you haven't figured out where the surgeon is, the surgeon's way over here in this little console right here. So the surgeon is sitting at a little console. They're not sterile. They're not scrubbed in. The assistant is standing at the table side, and and the surgeon is working the arms of the robot using this device. So in theory, the surgeon could really be anywhere in the world. This has some military applications where they were trying to use very high-speed internet to see if you could control a robot from a distance. Obviously, this could have some implications for battlefield surgery, but this robotic surgery requires additional training. But we find that it seems to be most useful for these complex rectal cancers because the added magnification, the three-dimensional imaging, and the ability to have instruments bend can truly add to the ability to get lower around these cancers and potentially prevent patients from needing a permanent colostomy. So in summary about colostomies, the vast majority of colorectal cancer patients do not require a colostomy. Only 10% will require a temporary one, and less than 5% will require a permanent stoma. So this is the question patients want to ask, but typically won't because they're too scared. And the question obviously is, am I going to die? What is my prognosis? The prognosis in colon cancer is based on the stage at the time of diagnosis. When we look at that, what we're looking at is three main things. How deep does the tumor penetrate through the wall? That's what we call the T stage. Whether the lymph nodes are involved, that's called the N stage, and whether they spread to other parts of the body, the lungs or the liver, and that's the M stage. The most common question I'll get asked after I do a surgery by the family is how big was the cancer? Everybody equates a large cancer with a bad prognosis, and unfortunately, that's really not true. A large cancer may not spread to the lymph nodes, while a very small one may. So the big difference is lymphatic spread and depth of penetration, not the actual size of the tumor. When you look at stage, patients with a stage 1 cancer have an excellent prognosis, 90 to 95% 5-year survival. Stage 2, a little bit deeper, but the lymph nodes are all negative, 75 to 85% survival. Obviously, you see a drop-off between stage 2 and 3, and this is where the lymph nodes become positive. When we talk about stage 4 patients, the historical data obviously shows a significant drop-off in long-term survival, only 5 to 8% 5-year survival. But I will qualify that by telling you that most of this data predates recent advances in chemotherapy and radiation therapy. So I would argue these numbers are actually too low and the 5-year survival is significantly higher. But obviously, you can see the drop-off between 2 and 3 when lymph nodes become positive, and the drop-off between 3 and 4 when their cancer has spread beyond the colon. Other determinants of survival include specific factors of the tumor, how aggressive it is, or what we call the differentiation, whether it's spread into the lymphatic tissue or the nerve tissue around the colon. Obviously, the overall health of the patient makes a difference in what they can tolerate, including surgery and chemotherapy. And one of the things that's been clearly shown is the experience and the ability of the surgeons makes a difference. This is even more clear in rectal cancers, where procedures done by surgeons that don't do this very often have a significantly higher rate of recurrence. Now, this is really probably the most important part of the talk. How do we avoid this? And really, that's a very simple question and a simple answer. You just get a colonoscopy. Okay, because colon polyps are almost always asymptomatic when they occur, and colon cancers, similarly, when they're early, are asymptomatic, and therefore they need to be found and removed before we're dealing with a cancer that needs a colectomy. Waiting for symptoms to occur increases the chance that the tumor will be found at a later stage. And as we talked about, 75% of patients have no family history. Unfortunately, we'll talk to patients who we tell them they need a colonoscopy because they meet the age criteria, and they'll respond, well, I know I don't have polyps because of not having any symptoms. And you'll try to explain this to them, but they're very certain that they don't have polyps. Nobody in their family had a cancer, and therefore they're pretty certain they don't have a cancer. Colonoscopy is very simple. It's nothing more than a fancy camera. You place the camera in the anal canal. We pass it through the colon to where the appendix right here, the small intestine, and the colon join together. And then on the way out, we just take a nice careful look around, and most of the time we're going to find nothing. About 30% of the time we'll find a polyp, and the majority of these can be removed right there. So colonoscopy is more than just finding cancers, it's actually preventing them. You find a polyp, you remove it, we can clearly show that this is preventing the progression of those polyps that we talked about over 7 to 10 years from a benign polyp to a cancer. The procedure is very comfortable, it's done under sedation. Most of the time we have an anesthesiologist administer the sedation. It's very safe, and it clearly saves lives. So who should get a colonoscopy? Basically, your first colonoscopy should be at age 50, and then if normal, repeat it every 10 years. There is literature supporting that African Americans should have their procedure done at 45, but I will qualify this by saying that not every insurance carrier will agree with that. Family history of colon cancers, patients who have that should get a colonoscopy at 40, and if normal, they get it every 5 years. And the one caveat to that is if the family member was under the age of 50, the first colonoscopy should be 10 years prior. So if a family member had a colon cancer at age 45, a brother, sister, or child should have their first one at 35, and then once again repeating every 5 years. If there's a very strong family history, then we should consider genetic testing, and that's something you would talk to your doctor about and potentially see a genetic counselor for. And that is what I have today to talk to you about, and I would be happy to entertain any questions. And then I can show a few videos on some robotic procedures to help people understand what we were talking about.
Great. Well, thank you, Doctor. We do have some questions that have come in. Some are fairly simple, some a little bit more complex. But let's start with the notion of polyps. Does the size of the polyp, is that indicative of anything? If someone, I guess, had a colonoscopy and the polyp was a certain size, I think they said 5 centimeters, does it matter how big the polyp was?
Well, the size of the polyp in of itself isn't always a determination of whether there's a cancer there, but certainly larger polyps do tend to harbor more frequently. And if the polyp were to come back benign, it may change the frequency of when we would recommend the next colonoscopy. So if a patient had a 5 centimeter polyp, instead of, and it was removed, we might recommend a shorter interval, say 2 or 3 years until the next colonoscopy instead of 5. But a lot of what really makes the difference is when that polyp is removed and looked at. Polyps have more than just polyp or not polyp. They can have different features. Tubular adenomas or tubulovillous adenomas or villous adenomas. As they approach the cancer, they become more and more unlike normal tissue. So part of what we have to determine is both size and the characteristic of the polyp. That lets us determine whether patients need more frequent evaluation of that site or whether or not anything else needs to be done. So the answer is yes, to some degree, but not entirely.
Okay, so if you get a diagnosis and they tell you that the polyp is nothing to worry about, maybe you should you press the physician to say, tell me exactly a little bit more about the makeup of the polyp?
Well, I think typically what we'll do is we will send the patient a copy of their pathology with a letter explaining it to them. So, it's always for patients to keep a copy of the type of information, especially patients who may be moving or following up with somebody else in the future. It's always a little bit of a problem when patients present and they tell you, I have a history of polyps, but they really don't know what they had. But nothing to worry about is kind of a generic term. So
yeah.
I think you should know a little bit more than you had a polyp. It is appropriate to ask, well, what type of polyp? Should I be having my colonoscopy in 5 years, or does it need to be more frequent? Because there are certain polyps that actually have no risk whatsoever. We call hyperplastic polyps, and those polyps don't need to be followed up any more frequently than the 10 years that a normal person would have. So yeah, I would agree that a little bit more information is certainly helpful, and I think everybody should keep a copy of their pathology report if they are diagnosed with polyps. It's certainly helpful for following patients in the future.
Okay. You mentioned Crohn's disease. Someone asked a question about diverticulosis or occasional diverticulitis. How does this impact the possibility of colon cancer, and what other problems does diverticulitis raise?
Well, Crohn's disease is separate. Crohn's disease definitely has a higher incidence of colon cancers in patients that have active inflammation. And those patients will typically, because of the underlying nature of their disease, are followed very closely with their gastroenterologist, and they will get more frequent colonoscopies because they definitely have a higher risk. As far as diverticulosis and diverticulitis, those do not place patients at higher risk of colon cancer formation. They have their own problems with abdominal pain and other risk factors that could require colon surgery, but in of themselves, they do not present increased risk of colon cancer formation. So a patient who has known diverticulosis or a history of diverticulitis doesn't need a routine screening colonoscopy any more frequently than the average person, unless, of course, they develop some form of a symptom that raises concern, and then their doctor would, consider a colonoscopy at that point, but it is not a routine requirement to have more frequent evaluation.
Okay. Question came in about polyps. Do polyps appear anywhere else on the body that would indicate that there's a potential for them being in your intestine or colon, or is that pretty much the only place they show up?
No, there are patients that have polyps in other parts of the GI tract, the stomach, and the small intestine. These are far more rare, but patients with syndromes like FAP can get polyps throughout their GI tract, and in fact, some of those patients who have even had their colon taken out for FAP do need to have special upper endoscopies performed by their gastroenterologist looking for those type of polyps. But those are far more rare than polyps of the GI tract. Small bowel, just a normal person, rarely gets cancers and rarely gets polyps. It's not that it can't happen, but the incidence is so much lower that routine screening would not be considered safe or effective.
Okay. Someone wanted to know, do you have an opinion, is there such a thing as a virtual colonoscopy now where they basically just take an image?
Yes, the virtual colonoscopy has been around for several years, and it has some good and some bad to it. Some of the good is that when we can't perform a colonoscopy on a patient for whatever reason, they're intolerant of it, or for anatomic reasons you can't pass the scope through it, we can obtain a virtual colonoscopy. And what a virtual colonoscopy is, it's a CT scan using three-dimensional reconstruction of the GI tract, and the radiologists are able to look at the colon and look for polyps inside of it. It requires a little bit longer of a CT scan. It also requires the same bowel preparation that we currently do for colonoscopy. So some people think they're going to avoid a whole bowel preparation and get it, quote, virtually. Unfortunately, it's the same bowel preparation. It also requires air to be administered into the colon so that the colon can be seen better. Currently, it's most insurance companies won't pay for it. Medicare doesn't cover it. It's never really been clearly studied in patients who are deemed higher risk with, say, family histories, personal histories of polyps, or a history of colon cancer. For those patients that do opt to pay for it themselves, the recommendations for screening actually drop down to every 5 years if normal versus every 10 for a colonoscopy. So there's a little bit of difference between the two. In general, it's not used currently as a routine screening methodology.
Okay. I've got two more questions. One's a quick one, one's a little bit more complicated. Is there any age after which you do not need to have regular colonoscopy if you're a person with a family history of colon cancer?
That's a great question, and probably almost impossible to answer. So right now,
okay,
most societies recommend stopping colonoscopies on routine patients around age 75. It becomes a lot more murky when you're talking about what happens if you personally have a history of polyps, or you have a strong family history of polyps, or a family history of colon cancers. That age isn't so clear. And obviously, it really depends on the patient. So I don't use a cutoff. Personally, I kind of look at the patient. I have 80 and 85-year-old patients that are out, running, and I've got 40-year-old patients that can barely move. So it's really hard for me to tell an 80-year-old that would be willing to have a colon infection if they were found to have an early cancer to simply stop being screened because they've reached a certain age, if they have a strong history that may predispose them to that. It's 75 in general for most people who with no history at all, but when you start getting into those patients that are higher than average risk, it becomes unclear.
Okay. Last question here. Gentleman's gastroenterologist told him in 2011 that after his colonoscopy, he did not need another one for 5 years. He'd been on a 3-year cycle due to colon cancer in the family. His mother had died of it. He had a colon resection of the ascending colon in 2001 to remove something called a flat polyp on the colon wall. Since 2001, he's had 3 more colonoscopies with no serious problems discovered. Question, what likelihood could he develop cancer in the sigmoid part of the colon? And would you recommend another colonoscopy prior to his January 2016 5-year mark since his last one?
Okay. Well, the answer is he does have a higher risk of forming another cancer. Well, I guess he didn't have a cancer, a polyp. He could form another polyp because he had it. So patients with a history of polyps do have a higher incidence of forming them. That's why the recommendations drop down to that 5-year interval. So in his case, I would stay with the 5 years. I think it's very reasonable if he had a flat polyp to go at a shorter interval. Typically, we'll go 1 year after the colon surgery After that, depending on what was found, you would tend to push that out a little bit. I would tend to go 2 to 3 years. If that's clear again, then I would agree sticking with 5 years and then every 5 years, unless, of course, another polyp was found and required shortening the interval. But most people can eventually get back to that 5-year window as long as their colon is staying under control and can be followed and everything looks good. So for what you're telling me, stick with the 5-year. I think that's what.
Okay, and for the benefit for the rest of our audience, would you just define what is a flat polyp? Is that something different?
A flat polyp, I don't think I have a picture, but basically you can think of polyps, a kind of a standard or easier to think of polyp is almost like a tree with a stalk and leaves, and you can easily grab the base of it with a little lasso and take it out. A flat polyp would be more like a shrub. It would sit flat on the wall of the colon. There's really no way to get around underneath it and take it out right at the base. So those polyps can be very difficult to remove, and as they get further along on towards the cecum or the ascending colon where the walls are thinner, if you have a large flat polyp and you try to remove it by grasping the base, you can put a hole in the wall of the colon and then require emergency surgery. So that's a situation where I would assume his gastroenterologist sent him to the surgeon because they felt it would be highly risky to try to remove it without putting a hole in the colon wall.
Excellent. Okay. Well, thank you, Dr. Stern. Why don't you go ahead? We still have about 20-some minutes. Why don't you go ahead and run through the videos for those people who are interested, and then we'll wrap it up.
Okay. So this is going to be a video of a robotic portion of a right colon resection. And what I'm going to try to show here is the robotic instruments and their ability that lets us suture. Now that's one of the advantages that it's really hard to do laparoscopically to suture, because in 2 dimensions it's very hard to judge depth, and when you're trying to suture it's very hard. And then you can see in this video these instruments bend. So the tips of the instruments bend, and it allows the surgeon to have precise control as they're suturing these 2 sides of the bowel together. And the 3-dimensional imaging, of course, I can't show you that because everybody here is looking 2-dimensionally, but in a 2-dimensional standard laparoscopic approach, basically you're relying on your brain to interpret distance, and unfortunately your brain isn't always right. So when you reach in to grab something, you'll either grab past it or grab too short. And when you're trying to suture, that becomes very problematic because your brain isn't really able to tell exactly where those limbs of the bowel are. This right here is showing 2 holes being made in the small intestine and the colon, and we're putting a stapler up into these holes. And what we're going to do is we're going to join these 2 bowel loops together. One's the colon, one is the small intestine. So the stapler has just basically put a row of staples here and cut a common channel out. This little hole right here, if this was laparoscopically, we'd have to sew this whole thing closed, and it would be, to say the least, mind-numbingly painful for the surgeon. But when you do this with a robot, you're able to, with confidence, suture here. You have depth perception, you have fine movements. One of the things the robot also does is it takes away any tremors in the hand. Everybody has a tremor. The robot completely gets rid of that. You can see here the surgeon is able to suture here and tie the knots, which is a very difficult task laparoscopically because of the depth perception issues. And as a result, you can do this very fine suturing. You can do all these connection points internally. And what this does, it allows us to change the operation. Typically for laparoscopic right surgeries, we have to make an incision around the belly button to pull the colon out and pull it and put it back together, because we do all the work outside the body. When we do it robotically now, we connect everything inside, and what we do at the end is we make a very small incision near the pubic bone, and we just take out the area with the cancer through that site, and we can get rid of the incision near the belly button. And what that lets us do is get rid of a lot of the pain associated with that incision, and it also lets us get rid of much higher risk of wound problems, hernias, that occur when we put incisions near the belly button. So this was just an example of some of the skills that the robot allows you to have that just really don't exist when you go laparoscopically. The second video is going to be a video of a rectal cancer surgery, and as I was saying before, I think this is where the robot really makes a difference. Obviously you once again don't have the 3-dimensional vision, but I'm hoping you can see the ability of the robot to work very in a very fine manner, and you can see these instrument tips are bent. They're bending as they're being operated on. This area here is behind the rectum. This very fine plane here looks pretty big on the screen, but it's actually probably only a few centimeters wide. The tenfold magnification makes this easily visible to the surgeon. When we do these open, we have to have one or two people pulling with all their might just to expose this plane. This typically is the days that I don't wind up going to the gym because I pulled so hard. You actually can be sore. When you go with the robot, you can now just basically see this plane developing, this very clear plane. Here's the plane being opened up with this instrument. It's using electrical cautery, and you can see how nicely it's being developed. You just never see anything like this in open surgery, and even laparoscopically. You can't obtain these views, and you don't have instruments that can do this. So this is where I was telling you the robotics are allowing us to do surgeries that we probably couldn't do before, getting lower in patients that have a very narrow pelvis, in men more than women, and in obese patients where we really can't see. And this may be where we can preserve function. This right here is a stapler dividing the rectum low down after all that work was done, and then the connection will be made at a later point. This is just the rectum being taken out right here, and that's the whole rectum being brought out. This is right here the connection being made. This right here it's going a little fast, but this is a stapler being brought up from below, the top of the colon being connected down, and then the two are brought together, and using basically a circular stapling device, we connect the colon to the remaining rectum, and now we have a connection that's complete. And I think that's it.
Very good. Well, thank you very much, Doctor. We had a very engaged audience. I appreciate everyone's participation, and of course, we appreciate your working with us on this, Dr. Stern, in the presentation as well. If anyone has any additional follow-up questions, you can refer back to the email invite that you got, and you can